Hello everyone, welcome back to the series of lectures in gastroenterology. Today we will be learning about another very important topic, which is your approach to malabsorption and the disorders of malabsorption. So let's begin. So firstly, we have to know these two terms. What are the two terms? We have to know the difference between malabsorption and maldigestion. So malabsorption basically means that there is a problem with the absorption. So in the intestine, we know that there is a mucosal surface, right? So if the food particles are here, then it has to get absorbed through the mucosa and then goes into the bloodstream. So a problem with the absorption is what we call as the malabsorption. But what happens is that the food which is there in the lumen, if it is not getting digested properly, maybe because of some enzyme defect or maybe because of a motility problem. So the problem which is there with the digestion is what we call as a maldigestion. So this is the basic difference between maldigestion and malabsorption. So what is the most common symptom of any malabsorption? The most common symptom will be diarrhea, right? So we need to know what exactly is diarrhea. So diarrhea is defined as an increase in the stool volume to more than 200 ml in 24 hours, or increase in frequency of stool, or change in the consistency of the stool. Or increase in the stool volume to more than 200 ml in 24 hours, or increase in the frequency of stool, or change in the consistency of stool. So this is how we define diarrhea. Now let us understand the basics of all of the nutrient absorption, lipid absorption, carbohydrate, protein absorption, before we understand what is malabsorption. So let us look at how this lipid undergoes absorption. So the lipids which are there, the dietary lipids, they are in the form of triglycerides which are broken down to fatty acids and monoglycerides. Okay. So the lipid absorption predominantly takes place in the stomach and in the intestines. Right. So the triglycerides which are obtained from the dietary lipid is broken down into free fatty acids and monoglycerides. And this is brought about by a process called lipolysis, which is happening with the help of your pancreatic enzymes. So, any problem with your pancreatic lipase, okay, this can happen when there is pancreatitis, right? So, pancreatitis basically causes lipid malabsorption because of the deficiency of pancreatic lipase. So, there is a problem with the lipolysis where triglyceride is broken down into free fatty acids and monoglycerides. Okay. These free fatty acids are then undergo solubilization with the bile acids which are secreted from the liver. So bile acid is secreted from the liver, and this bile acid helps in the formation of a micelle, right? So the monoglycerides undergo solubilization with the bile acid to form a micelle. Bile acid deficiency basically results in a defect with the micellar formation. Okay. Now once the micelles are formed, then they enter the jejunal mucosa. So within the jejunal mucosa, they undergo absorption. Once they undergo absorption, they are esterified to form your cholesterol or chylomicron. Okay. So they are esterified to form your chylomicron. So an absorption defect is seen in conditions like celiac disease. Then these chylomicrons are then taken up into the lymphatic system. So then they are used in the peripheries. So this taking up by the lymphatic system, it is damaged in conditions like lymphangiectasia and A-beta lipoproteinemia. Okay. So this is an example of how at every stage the lipid absorption can be affected, but the etiology can be different. Okay. So first step is the deficiency of pancreatic lipase. When there is pancreatitis, then the lipolysis itself does not happen and there can be lipid malabsorption. Second, in bile acid deficiency, there is a defect in micelle formation. Third, in processes which directly affect the absorption such as celiac disease, there is a problem with the transport of micelles into the jejunum. Then after the jejunum, the phospholipid and the chylomicrons are transported via the lymphatics, and this can be affected in your lymphangiectasia and A-beta lipoproteinemia. Carbohydrate. So carbohydrate, how is it broken down? The starch is broken down by salivary amylases and pancreatic amylases. So disorders which basically affect the pancreas like pancreatitis can cause carbohydrate malabsorption as well because of deficiency of pancreatic amylase. Then in your intestines, you have transporters like GLUT5 and GLUT2. So any disorder of the intestine, for example, if there is a small intestinal bowel overgrowth. So what happens here? There is a bacterial overgrowth of all the bacteria which are not required, right? So this can cause a carbohydrate malabsorption. There can be a problem with the absorption like in your celiac disease. So that itself can also cause carbohydrate malabsorption. Similarly for proteins, it is broken down by pancreatic peptidases. So pancreatitis also can cause protein malabsorption. So this is about how the different types of diseases can cause different types of malabsorptive processes. Now let's move ahead. How do you classify your malabsorption syndromes? Now we have already learned what is maldigestion. So the first type is there is inadequate digestion. That is, there is a problem with not the absorption but a problem within the lumen of the intestine such that the food particles are not getting digested. So this is seen in post-gastrectomy or deficiency or inactivation of pancreatic lipase. Then exocrine or endocrine pancreatic insufficiency. So then you can have a pancreatic lipase deficiency. Then chronic pancreatitis, pancreatic carcinoma, cystic fibrosis or certain congenital causes. So all of these can cause maldigestion. Then drugs like orlistat can also cause maldigestion. So orlistat is basically a drug used in the treatment of obesity. So because it causes maldigestion, you feel early satiety and hence it's used in the treatment of obesity. Then it can be due to reduced intraduodenal bile acid concentration or impaired micelle formation. Just now we had seen bile acid deficiency because of chronic liver disease or because of biliary autoimmune diseases like primary biliary cirrhosis, primary sclerosing cholangitis, where bile acid itself is not getting secreted to the intestine. So chronic parenchymal liver disease, cholestatic liver disease, right? Then the third mechanism we had already seen is a process of maldigestion, which is your bacterial overgrowth. This can be because of stasis, where there is anastomosis stasis post-surgery, or functional status because of mobility problems in diabetes, scleroderma and so on. Then there can be an interrupted enterohepatic circulation of bile. So we know that the bile gets secreted in the intestine and then it forms urobilinogen. So in the intestines it is deconjugated to form urobilinogen by the intestinal flora, and this urobilinogen is excreted. But 20% of the urobilinogen undergoes an enterohepatic circulation. So this itself can be impaired because of ileal resection or Crohn's disease, which are diseases which affect the intestine. Okay, and also drugs like cholestyramine. So this is about what are the causes of maldigestion. So maldigestion can occur due to pancreatic problems, it can occur due to drugs, it can occur due to bacterial overgrowth, it can occur due to bile acid deficiency and a problem with the enterohepatic circulation. Then we will look at the second mechanism where there is an impaired mucosal absorption. Now it is not digestion, we are discussing how the absorptive processes can be affected. So this can happen due to inflammation or infiltration or infections. Inflammation or infiltration or infections. So inflammatory conditions like Crohn's disease, amyloidosis, lymphoma, eosinophilic enteritis, tropical sprue, all these malabsorptive disorders can cause inflammation. Then celiac disease, then infections like Whipple's disease, okay, or infections like giardiasis. Then genetic disorders can be because of deficiencies like A-beta lipoproteinemia, A-gamma globulinemia, and then you have Hartnupp's disease, cystinuria and so on. Then there can be impaired nutrient delivery to and from the intestine. Basically what we had seen is absorption into the lacteals or the lymphatic system will be affected. This is seen in lymphatic obstruction like lymphangiectasia. Okay. Then endocrine and metabolic disorders can directly or indirectly affect the bowel motility and hence they can cause malabsorption. So this is about the etiology of malabsorption. Okay. So I hope we are clear till here. So what all have we understood now? We have understood about the approach to malabsorption. We have seen how and what, at which stages, how are the nutrients absorbed and how does each of these nutrients get affected at each stage of their absorption. And we have understood what are the causes of maldigestion and what are the causes of malabsorption. Okay. Now let us move on and let us understand what is the difference between this important concept of bile acid diarrhea versus fatty acid diarrhea. Okay, so let us understand that there is one factor which is called as FGF19. So FGF19 is nothing but your fibroblast growth factor 19. So what is the function of this FGF19? FGF19 is the one which is basically inhibitory to the bile secretion. It inhibits the bile secretion. So sometimes there can be genetic conditions where there is decreased FGF19. If there is a decreased FGF19, then what happens? There is increased bile secretion. Okay? There can be increased bile secretion. Now this increased bile secretion spills over into the intestine. It spills over into the intestine. And when it spills over into the intestine, it causes irritation of the intestine. It causes a form of secretory diarrhea. Okay? So all this while what we had learned? We had learned that malabsorption happens because of enzyme deficiencies or even bile acid deficiency. Right? So if the bile acids are low because of chronic liver disease or any problem with the biliary tree, you can have malabsorption. And the diarrhea that accompanies that is your fatty acid diarrhea because there is a lipid malabsorption. But you should be aware that there is another type of diarrhea which is called as your bile acid diarrhea. So the principal difference here is that the bile acid is in excess. There is increased secretion of bile acid because of decreased FGF19, which is a regulator of bile acid secretion. And this in fact causes a secretory diarrhea and it has to be differentiated from malabsorption. So this is not a malabsorptive diarrhea. It's actually a secretory diarrhea. Okay, that is why you should be aware of this. So what are the key features or the key differences between your bile acid diarrhea and your fatty acid diarrhea? So what happens to the extent of ileal disease? In your bile acid diarrhea, sometimes even an ileal problem can cause deficiency of FGF19. But here it is a very limited disease. In fatty acid diarrhea, you can have extensive ileal disease, right? Extensive ileal disease causing an impairment in the enterohepatic circulation. There is an impairment in the enterohepatic circulation and hence there is a bile acid deficiency. There is a bile acid deficiency in your fatty acid diarrhea. Here the bile acids are in excess. Okay? Fine. So the ileal bile acid absorption is reduced here is reduced in both. Then the fecal bile acid excretion, hence because the bile acid is more, fecal bile acid excretion is more in bile acid diarrhea and fatty acid diarrhea as well. Okay. Now the most important thing is that the bile acid pool size is normal, but it is reduced in fatty acid diarrhea because here there is excess amount of bile acid production, right? So the bile acid pool is normal, but here the bile acid production is reduced. There is a decreased enterohepatic circulation, there is a bile acid deficiency. Okay, and the steatorrhea is more than 20 gram in fatty acid diarrhea. There is no steatorrhea in bile acid diarrhea. So bile acid diarrhea will respond to cholestyramine, but this fatty acid diarrhea will not respond. Cholestyramine is a bile acid sequestrant, right? So here there is excess of bile and spill over into the intestine. If you give cholestyramine, it sequesters the bile acid. So this is a sequestrant. So it decreases. So there is response to cholestyramine in bile acid diarrhea, but there is no response in fatty acid diarrhea. Then the response to low fat diet will be there in which one? In fatty acid diarrhea, but it is not there in bile acid diarrhea. Okay. So this is about your bile acid diarrhea and fatty acid diarrhea. Very, very important. Fine. Now let us move on. So now let us discuss how do you approach your patient with malabsorption. So how do you approach your patient who is presenting with malabsorption? So how do they present to you in terms of history? In terms of history, they will present with a vague abdominal pain. They will present with diarrhea. So when they present with diarrhea, what are the things that you have to ask? You have to ask whether this diarrhea is foul smelling, how much is the quantity of stool, what is the frequency, what is the consistency of the stool. Then you have to see whether this is a foul smelling stool or if it is floating in your pan, then there could be evidence of steatorrhea. And then you have to know whether this is a bile acid or a fatty acid diarrhea. Okay. Then you also ask about weight loss. Why do you have to ask about weight loss? Because chronic malabsorption, there's going to be a chronic nutrient deficiency. Then these patients can be associated having bloating. Okay. Because in many of these malabsorptive disorders, there can be impaired digestion and there could be excessive production of gas, which results in bloating. Also, we have to ask about surgeries, because many of the abdominal surgeries usually result in decreased length of the intestine. So, overall the absorptive surface is decreased and it can result in malabsorption. So, they can have abdominal pain, diarrhea, weight loss, bloating, and history of surgeries is very, very important. On examination. So, on examination, what all will you look for? So, you have to look for 1. Anorexia, weight loss, malnutrition. This is mainly because of whenever there is malabsorption, there is going to be a nutrient deficiency and weight loss, right? Then in your diarrhea, what all will you ask for? This we had just now discussed. You look for your volume of stools. Is it a small volume or a large volume diarrhea, right? Small volume stools is a large bowel etiology. Large volume diarrhea is a small bowel etiology. Then you have to talk about the consistency. You will have to talk about the frequency. You will have to also ask if it is blood stained or not, to differentiate whether this is a malabsorptive diarrhea or an inflammatory diarrhea like your IBD, or is it due to infections. Okay, fine. Then you have to ask about flatus. There is flatus because of excessive production of gas. Then what are all the vitamin deficiencies that can occur because of malabsorption? Predominantly the fat-soluble vitamins, vitamin A, D, E and K you can have with. So whenever there is a lipid malabsorption, there can be deficiency of your fat-soluble vitamins as well. But not only that, in severe malnutrition and severe malabsorption, other vitamin deficiencies can also be seen. So you can have evidence of vitamin deficiencies like glossitis, stylosis, stomatitis because of deficiency of iron, B12 and vitamin A. Then you can have abdominal pain. The abdominal pain can be because of small intestinal bacterial overgrowth, it can be because of diverticulitis, it can be because of pancreatitis as well. Then bone pains. Why? Because there is chronic malabsorption can result in chronic vitamin D deficiency, which can result in osteoporosis and which can result in osteomalacia as well. So, calcium, vitamin D, protein deficiency, osteoporosis, all of this can cause bone pain. Then tetany and paresthesia, mainly because of calcium and magnesium malabsorption. Then weakness. Weakness can be because of multiple things. It can be because of anemia, right? So we know that both iron and B12 deficiencies can occur as a result of malabsorption, right? Because both of them are absorbed from the intestines. So anemia itself can cause weakness. Apart from that, electrolyte depletion. Chronic malabsorption can cause hyponatremia, it can cause hypokalemia. So all of these can contribute to your weakness, particularly potassium. Then azotemia and hypotension, because of your fluid and electrolyte disturbance, they can have a low BP. Then amenorrhea, decreased libido, because chronic malnutrition basically suppresses your GnRH axis and you can have loss of libido and amenorrhea. Then bleeding. Why? Because of vitamin K deficiency. Whenever there is a fat malabsorption, you can have vitamin K deficiency and you can have bleeding. Then night blindness, vitamin A, peripheral neuropathy, vitamin B12 and thiamine deficiency and dermatitis, right? So a head to toe examination becomes very, very important in your malabsorptive syndromes. Apart from the examination, on the laboratory findings, what will you find? You can find anemia, right? You can find thrombocytopenia. And in your LFT can be deranged. Albumin is a marker of chronic inflammation as well, so you can have hypoalbuminemia, okay? And some amount of AST, ALT derangement can be there with chronic malnutrition, okay? Fine. So this is about your various examination findings in malabsorption. Now, let us look at the tests which are done for the diagnosis of malabsorptive syndromes. So first, iron deficiency anemia, right? So how do you diagnose iron deficiency anemia? So serum iron will be low, then TIBC, total iron binding capacity, will be high, okay? So serum iron is low, TIBC is high and serum ferritin is decreased. Serum ferritin, because ferritin is a storage form of iron. it is reduced. And where do you get iron deficiency anemia? We know that iron is absorbed from the proximal small intestine. So diseases which affect the proximal small intestine are associated with iron deficiency anemia. Now, B12 deficiency, B12 is basically absorbed predominantly from the ileum. So, diseases which affect the ileum, for example, Crohn's disease or tuberculosis, right? So, all of these can cause B12 deficiency. B12 deficiency results in a macrocytic blood picture. There are some disorders which can affect both proximal and distal small intestine. So, it can have both iron and vitamin B12 deficiency. For example, your tropical sprue. Okay, fine. Then, what are the tests we do for fat malabsorption? Till now, we were looking at your general profile, what are the kind of deficiencies and how will you have a clinical diagnosis of malabsorption. Now, there are specific tests to look for fat, carbohydrate and protein malabsorption. What are those tests we will look at? So, fat malabsorption, quantitatively we call it as steatorrhea when the stool fat examination quantitatively is more than 7 grams in 24 hours. So, when you do a stool fat examination quantitatively and the value is more than 7 grams in 24 hours, we call it steatorrhea. Clinically, how does steatorrhea look? If you ask a patient, how will you ask for steatorrhea? So, this is characterized by foul smelling stools which basically float in the pan and they are difficult to flush. Okay, and they are very greasy foul smelling stools. So, greasy foul smelling stools because of excess fat. The qualitative test is stool staining for Sudan black. Then we also do a breath test, which is your carbon-14 labeled triolean breath test. But since there is radioactive exposure to carbon-14, it is less commonly used. Then carbohydrate malabsorption. So for carbohydrate malabsorption, we predominantly look at the integrity of the jejunum. So the most important test that is used here is your D-xylose test. So in this D-xylose test, what we do is 25 grams of oral D-xylose is given. Okay? And you check for the urinary excretion of D-xylose. If the urinary excretion of D-xylose is less than 4.5 grams, that means that there is a problem with the carbohydrate absorption. The next test that we do is a hydrogen breath test. Okay, in this hydrogen breath test, what do? We basically use it for finding lactose intolerance. So, in patients where there is lactose intolerance, we use a hydrogen breath test. So, an analyzer is used and it is reported in terms of parts per million. Then for protein malabsorption, the test that is used is your stool elastase test. Okay, fine. So, the next important test that we should know is your stool osmolar gap. So, what is the formula for your stool osmolar gap? It is given as the serum osmolality minus 2 into stool sodium plus stool potassium. Okay, so this is given by the formula, the osmolality minus of 2 into stool sodium plus stool potassium. Now, what is the use of the stool osmolar gap? It can be used to find out whether the cause of the diarrhea is mainly because of an osmotic diarrhea or a secretory diarrhea. Osmotic diarrhea means what? Osmotic diarrhea means that there are certain high osmolar substances in the intestine. For example, lactulose, right? For example, lactulose, right? So, this basically causes withdrawal of the fluid along with this and causes a osmotic diarrhea. Now, because of this high osmolality, what happens is that within the mucosa, it pulls in the water along with that and causes osmotic diarrhea. In your secretory diarrhea, what happens? In secretory diarrhea, there is damage to the intestinal epithelium. There is damage to the intestinal epithelium mainly because of toxins or because of infections, as a result of which there is increased production of water and electrolytes by the damaged mucosa, which basically causes your secretory diarrhea. So, how does the stool osmolar gap help here? If the stool osmolar gap is more than 50 to 100, then this is a osmotic diarrhea. If the stool osmolar gap is less than 50, then this is a secretory diarrhea. Okay, so these are the various tests which are used in your diarrhea and in your malabsorptive syndromes. Fine. So we have learnt about the test for fat, learned about the test for carbohydrate malabsorption and protein malabsorption. Now let us understand what is the next diagnostic test or the definitive test which can be used for the diagnosis of your malabsorption cause. So there are certain conditions in which if you take an intestinal biopsy, you do a colonoscopy and do a biopsy, the changes can be used to identify what is the cause for your malabsorption. So Whipple's disease, how is it diagnosed? So in Whipple's disease, what do you find? You find PAS positive macrophages. So what do you find? You find PAS positive per iodic acid skip staining if it is done. So per iodic acid skip staining if it is done, you find PAS positive macrophages in the lamina propria. In A gamma globulinemia, you can find no plasma cells and absent villi. In lymphomas, you can find atypical lymphocytes which infiltrate into the submucosa. In lymphangiectasia, what happens? There are abnormal lacteals, right? So this is a post-absorptive defect. So you can find that there are dilated lacteals like this. You can find dilated lacteals on the biopsy. What are the histopathological changes in celiac disease? You will have crypt hypertrophy, villus blunting, and an infiltrate into the intestinal mucosa. Tropical sprue also has the same histopathological changes as in celiac disease. In amyloidosis, you can find amyloid deposits in the intestine. Okay, so this is about how the biopsy helps in the diagnosis of malabsorption. Okay, so with this we have come to the end of the chapter on approach to malabsorption. So what have we learned till now? So we understood what is the difference between malabsorption and maldigestion. We have understood what is your definition of diarrhea. Then we looked at how each of the nutrients are absorbed and how malabsorptive processes can affect each of these stages of absorption. Then we have understood the classification and the etiologies. We have understood what is the difference between your bile acid and fatty acid diarrhea. Then we have understood how do you approach the patient, what are the clinical findings, what are the different tests that you have to perform for the diagnosis, and how does the biopsy help in the diagnosis of malabsorptive syndromes. In the next session, we will be discussing about certain specific malabsorption related disorders. Thank you.